Okay. All right, welcome guys to the first talk of the neurology series for 2022. The emphasis and main aim of these talks is not to provide exhaustive detail about each of the disorders that we'll cover in the next few weeks. It's more to provide you an efficient way to recognize disorders and what to do about them. So, you know, in a clinical context. So rather than what you read in a textbook, which is often quite lengthy, it's more about recognizing the disorder in a patient on the wards and then knowing what to do about it if you need to do anything about it. So that's the emphasis of the talks. So with that as an intro, we're starting with transient ischemic attack and stroke. For the reason that they're so common, it's the most common disorder in neurology, and as a junior doctor especially, you see a lot of this on your calls. So I like to provide some history. Apoplexy. I'm not sure if too many of you have heard of the word apoplexy, but that is what stroke has actually been called for most of human, civilization's history. So apoplexy was a fairly non-specific term, and it means literally struck down by violence. And Hippocrates was actually the first person to describe it in its relation to stroke, and he was describing strokes, both hemorrhagic and ischemic. And basically, the person would sort of have a sudden paralysis, but otherwise, their heart rate would remain more or less regular. Their eyes might be closed, and they hemodynamically would be somewhat okay for a while. But if you read a lot of historical novels, that word pops up quite a bit. So it's good to know about it. It was actually only about just over 3 centuries ago that a Swiss pathologist named Jacob Wepfer, he actually split the definition of apoplexy into two things. He said, well, there's some of these apoplexies result from a brain hemorrhage, and some of them result from an obstruction of a blood vessel in the brain. So he was differentiating between hemorrhagic and ischemic stroke, essentially. And by the late 1600s, I think 1689 was the first year, it was actually written down. The term stroke started to be used to describe these disorders. I should say the word apoplexy probably was used to refer to many of the things that were not either of these kinds of strokes as well, because it was such kind of a vague definition. So that's good to know. Not even a century ago, we introduced the term cerebrovascular accident, which was very unfortunate because not only is it very non-specific, I think the problem was the word accident. Because as you should know, the risk factors for stroke, both ischemic and hemorrhagic, are highly modifiable. And so you can actually really impact the chances of developing one in the future by purposefully modifying risk factors. And so it's not really an accident in that sense. And a lot of people got upset about that. So the way we refer to these things now, when you speak to someone over the phone, it's best to call it a hemorrhagic stroke or an ischemic stroke rather than a cerebrovascular accident. Definitely not CVA. Okay, now, up until about the 2000s, we used time-based definitions, and you might have learned some of this in medical school still, I suspect. This started in the 60s. We started defining TIAs and strokes, ischemic strokes, based on this sort of 24-hour time-based definition. So a TIA was defined as a neurological deficit of vascular origin that resolved within 24 hours, whereas a stroke was defined as a neurological deficit of vascular origin that persisted over 24 hours, fairly cut and dry by time, unless interrupted by death. Now, as soon as we started getting imaging in the 80s and 90s, we saw that these definitions had real problems. So we started getting advances in brain imaging. Some of the older doctors here might remember the pre-CT, pre-MRI era, although I don't think anyone here is quite old enough. And what we found was that these simple time-based definitions were somewhat inadequate. So when we started using CT scans, we found that up to 20% of the so-called TIAs by that time-based definition were in fact strokes. And MRI was even more extreme. We found that probably half of the so-called TIAs were actually strokes. And so with imaging, it became quite apparent that this definition was no longer suitable. So we now have moved on to tissue-based definitions. Just in the late 90s, more problems appeared with these other definitions. So for example, the 24-hour time cutoff after we had accrued enough data, it clearly became obvious that it was just too long because the majority of TIAs, the vast majority, actually resolved within 30 to 60 minutes. And so, in fact, when symptoms last over 60 minutes, the chances of it resolving by 24 hours and being a real TIA are less than 15%. In fact, it's probably a small stroke. So now we use these tissue-based definitions, coming back to them. We now define TIA as a sudden neurological deficit of vascular origin with the symptoms typically resolving within 60 minutes. Not always, but very, very frequently that's what happens. They fully resolve without evidence of infarction on imaging. And this is a more precise definition because you can quantify, based on your imaging analysis, whether there is an anomaly there or not. And the time thing is still sort of a part of it, but it's not the fulcrum of the definition. Stroke is the same thing. It's a sudden neurological deficit of vascular origin, and it can affect the brain, spinal cord, or retina of the eye. That's all stroke. But you have to see something on imaging. So the top image there is a CT head, obviously. And when you talk about CT, you talk about hyperdensity and hypodensity. So you can see that the circle is around a dark region. That is a hypodensity on the CT head, and that is a stroke. So even if that person had symptoms that resolved within, say, half an hour, that is still, which would have been defined as a TIA with the old definition, we now call that a stroke. It's quite clear that it's a stroke, as in neurons have infarcted. The bottom image is MRI imaging, and the circle, with MRI, it's not about density, it's about intensity. So we talk about hyperintensity and hypointensity, and that little white region is a hyper-intense signal on the MRI, and that indicates a tiny stroke on the MRI brain. So again, no matter how long the symptoms lasted, that is a stroke, not a TIA. So this is why imaging is so important in stroke. We use imaging actually as a biomarker to quantify whether this is a TIA or stroke or something else. It's just not a blood biomarker, which is what we normally think of with biomarkers. It's an imaging-based biomarker. Okay, so with that brief history and introduction, how do we diagnose and treat TIAs and strokes on the ward? So remember, I'm aiming at the simple concepts, not the exhaustive detail here. So the general approach is first you have to exclude a mimic. That's very important. There are a number of mimics. The second approach is that if you think this is more a TIA, based on the history, than a stroke, and we'll talk about how you incorporate the time factor still for that, even though it's not the absolute factor. You can stratify the imminent stroke risk and treat accordingly. So do they need to come in or not, basically. But if you think a stroke is likely, and particularly if it's a code stroke, and most strokes that come to the hospital now are called as code strokes, then one must perform a quick focused exam, history and exam, and order the appropriate brain imaging to see if the person is eligible for reperfusion. There's only two main reperfusion therapies, and we offer both of them, one on-site and one off-site in Auckland. And finally, this is very important and often not done exhaustively enough. On the ward, once all the dust is settled and the TIA or stroke is confirmed, and you're now seeing the patient every day on the ward, it's really crucial to identify and treat the etiology of the TIA or stroke. That's secondary prevention, because in fact, when diagnosing TIA or stroke is only halfway to the complete diagnosis. You need to know the source. Okay, so first thing, exclude a mimic. Now, there are lots of mimics, and obviously someone with a stroke is disabled. They might not be able to give you a great history, so you're going to often need collateral. Quick call to a family member, or hopefully there's a family member there. That's a little stick insect, obviously. Okay, now these are the two main mimics, in my opinion. From experience, these are the two that I think are the most common and difficult. So the TODS, or postictal paresis or paralysis. So after a seizure, particularly a focal motor seizure, a person will develop, nobody knows the pathogenesis of these, but there's some kind of dysfunction of the neocortex. The neocortex is the several millimeter thick ribbon of around the edge of your cerebral hemispheres. And that can be dysfunctional for up to 48 hours after a good going seizure. So that can present with all kinds of strange signs and symptoms. I remember as a registrar, I actually thrombolyzed a TODS paresis. The patient was fine because if you thrombolize someone who hasn't had a stroke, the risk of complication is exceedingly low, but still, I was fooled. You can have upper motor neuron signs and all kinds of interesting distributions and a marked degree of weakness. So that for me is mimic number one. We're going to talk more about seizures in the second talk of the series next week. The other one, though, is functional neurological syndrome, or FND. These are a very interesting group of disorders that are also can be quite difficult to differentiate. There are a number of fairly reliable clinical signs, which when you put them together, it allows you to do so. We're going to talk about that one in the third talk of the series. Hemiplegic migraine and cervical spondylosis. Hemiplegic migraine, nausea is very common, and obviously a headache and aura-like symptoms. Migrainous pathologies often build up over minutes and sort of peak maximally after an hour or two. So that's one thing, whereas TIAs and strokes don't present with that kind of a time course. TIAs and strokes are sudden and maximal intensity at onset, right away, boom, migraines build up. Cervical spondylosis, so pathology of the neck, the best way to identify those is person might have arm and leg weakness, but the face is totally normal, no problem above the neck. So if you have that, be very wary that maybe this is a cervical pathology. There are some other mimics. They are, in my experience, rarer. So hypoglycemia, obviously. Demyelinating disease can rarely present in a fairly acute fashion, as can a brain tumor. So those things, keep an eye out for, but I got to admit, they're much rarer. And I do also, as a registrar, it's great being a registrar. You're allowed to be fooled once by everything because, you know, you have a consultant who can take the heat, I guess. Bell's palsy. Bell's palsy doesn't always present in textbook fashion. It can be difficult. So if you miss any of these, don't worry about it. It happens to the best of us, I would say. And just know that there are many different mimics. And before you start going down the TIA stroke pathway, make sure it's a TIA or stroke. So this is very important. TIA and stroke, again, I'll say it, is they both show sudden maximal neurological deficits at onset. They don't tend to build up over time. It comes over a few seconds, boom, it's sudden, and it's maximal. If anything, it's going to get better. It's not generally going to get worse. There are always exceptions, but that's a reasonably reliable point in the history that one should clarify. Okay, so let's talk about TIAs first. With TIAs, it's all about stratifying the imminent stroke risk. So if you have a likely TIA on history, and that is defined by sudden maximal onset with rapid full recovery within 60 minutes. Remember, our most TIAs resolve fully within 60 minutes. Then you probably almost certainly got a TIA. You might have a tiny stroke that happened to recover fully, and if you do the imaging later, you'll find evidence of tissue infarction. But the chances are you have a TIA. And either way, you can treat them the same. So if a TI is likely, we use this thing called the ABCD2 score. It's a very simple scale, and that is to stratify the imminent stroke risk. There's a number of factors that you just tick off, as shown by what is circled there, and you get a score out of 7. And basically, a high stroke risk, and I'll show you the percentages on the next slide, is associated with any one of the following. So a score of 4 to 7, crescendo or recurrent TIAs, so person who has 2 or more TIAs in a very short period of time, within like a day or two, that is a very reliable marker for imminent stroke, and atrial fibrillation. So if any of those things are there, then one should really consider an admission. Oh, computer's frozen up. No, there we go. Okay, so how to use it. So basically, you calculate the score, and previous studies have shown that if you have a score of 0 to 3, you have about a 1% 2-day stroke risk. And so in that context, hospital observation is probably not necessary unless there is a crescendo pattern or atrial fibrillation or something else that concerns you in the medical history. As soon as you get to a 4, then the risk goes up appreciably. At 2 days, you're looking at over 4%. And if you hit a 6, you're at over 8%. So definitely admit the 6s and 7s. The 4s and 5s, I would admit too, because it's a very short workup for a TIA. It's a 24-hour workup, really, if the treating team knows what to do. And I think you'll probably save a few strokes from coming in if you manage things this way, and it's very simple. How do you treat a TIA? Now, I guess a lot of people don't know this, but if a TIA is likely, like you're very confident you have those features based on the history I talked about, and let's say you're working remotely and you don't have a CT, you can actually give aspirin and give some treatment without necessarily imaging them. because the chances of this being a bleed is virtually zero. However, at Waikato Hospital and in virtually all other cases, you're going to have imaging available. So in that case, you should image the patient before you do any treatments at all. And one of the main reasons is to exclude a hemorrhage. Now, if the TIA is low risk, so you have a score of 0 to 3 and there's no other complicating factors, you can just give your standard medications, the aspirin, the antihypertensive, and statin, and arrange an outpatient TIA clinic, ideally within 1 to 2 weeks. Of course, here we have, sort of 4 weeks is usually the earliest we can see them, so that's a challenge on the neurology department's part rather than anything else, but that's the ideal. And if the TIA is high risk, so score 4 to 7, crescendo TIAs or AF, just admit the patient, and you can do the imaging and still give the medications, but they should be admitted for workup. So regardless of which route you choose, there are really only 2 essential investigations for any TIA. And they're both aimed at finding out the source of the TIA. So that's your blood vessel imaging. So if it's suggestive that it was in the anterior circulation, so the front 2 sort of cerebral hemispheres part of the brain, then you can get a carotid ultrasound to look at the carotid. A CT angiogram also looks at the vertebral arteries. So if you have a posterior circulation TIA, you might want to get a CT angiogram. And then cardiac monitoring. If they're admitted, that would be 24 hours of telemetry in the stroke unit. If it was an outpatient setting, you can do something like a Holter monitor. Stroke is treated very differently from TIA. So if you have a neurological deficit that's been there for longer than an hour, that's probably a stroke, not a TIA. Ischemic stroke has 2 components. Okay, this is very basic stroke knowledge. Is essential to treating these people correctly. There is a core, and around the core, there's a penumbra. Now, the infarct core is beyond saving. It is infarcted. The neurons in that region are no longer salvageable. But the penumbra, which is often much bigger and can last for several hours, sometimes even longer, it is just stunned and potentially salvageable. The blood flow is still adequate to maintain the neurons' basic survival metabolism. However, they are unable to perform their functions. And so, remember, neurons are the highest energy demanding cells in the body, and they require a good amount of blood flow and oxygenation and so on. So what we're trying to do with stroke is save the penumbra in the acute phase. We're trying to save the penumbra, the core is gone. So to do this, we need to know how much is core and how much is penumbra, right? And that's the whole point of the code stroke, is to find out which is which and then decide if we should try to save the penumbra based on how much there is. And so to do this, we do a quick history and exam, and we do our stroke brain imaging protocol. Okay, so for a code stroke, you're on the wards, it's 3 a.m., and you get a code stroke. You go down, there are really 2 points of the history that are absolutely vital to clarify fully. The first is the premorbid function of the patient. So we do want a decent quality of life with independent function. That is very important. When you're talking about reasonably aggressive reperfusion therapies, then you'd like to know that there is a reason that you are doing them. Also, we have to clarify the time last seen well. It's really important not to clarify the time. It's good to know when they were seen unwell, but we must know when they were last seen well, because the stroke could have happened any time after the time they were last seen well. So, for example, in wake-up stroke, this is a classic issue. The person was found at 9 a.m. with symptoms of a left middle cerebral artery stroke. However, if they were found like that, then we have to take the onset time as potentially 8 p.m. the night before when they went to bed. So, and they were seen by a family member. So that's a bit of a rub in stroke. And we're trying to get around that with certain imaging protocols, but at this point in time, this is how it is. We want under 4.5 hours for thrombolysis, and we want under 6 hours for clot retrieval. Now, we can go up to 24 hours for clot retrieval if there's a very good patient that would definitely benefit from the treatment. And we use CT perfusion, which I'll talk about in a few slides, to determine that. There's only one absolute contraindication to thrombolysis, and that is ongoing hemorrhage at a non-compressible site. So brain hemorrhage, you can't compress the skull, or deep hemorrhage within the body that you just can't compress, you can't thrombolyze. All other situations are optional, because you may be dealing with a potentially life-ending stroke, a very big stroke. So it's worth the risk of bleeding elsewhere often to go ahead and try to reperfuse anyhow. For example, if they have a bleed on the arm and you can compress that and it's a big stroke, it's absolutely worth it to go ahead and just have someone compress that the whole time. So there are a number of relative contraindications, and a previous ischemic stroke within the last few months is one. Again, it's not an absolute. Previous occurrent hemorrhage anywhere else in the body at a compressible site. Previous occurrent malignancy anywhere in the body. It's not ideal to have cancer there. Cancer can bleed. However, it's all contextual. If it's a tiny cancer and it's been there some time and it's a compressible site, well, it might be worth going ahead. The possibility of pregnancy and the anticoagulation status. So we really do want the warfarin INR at 1.7 or lower. Above that, it gets you increase your risk of hemorrhage. And dabigatran, we want an APTT under or equal to 40. So part of the code stroke protocol is to get some bloods done. They should be done for you by the emergency department physician already. And if this is not the case, that's very interesting, because when someone's anticoagulated, they shouldn't have a stroke, right? So it gives you a clue as to maybe an interesting etiology. However, we can reverse these things to an extent if we do need to thrombolyze. So they're not absolute contraindications. Okay, code stroke exam is very simple. It's rapid. So the first thing, before you launch into the neurological deficits, check for hemodynamic compromise. If the patient has chest pains suggestive of a myocardial infarction, or dyspnea, like their breathing is labored, or they have a very high respiratory rate, or they're confused, they're encephalopathic, do not give thrombolysis. We must stabilize the patient before you can even consider administering another treatment such as this. And this is actually a problem, because it's you know, your adrenaline is up and you sort of really want to help this person with the stroke, and yet it can be very easy to miss the fact that their breathing is really labored. And I've fallen into this trap as well. Check the blood pressure in particular. When we thrombolyze, we want 185 systolic tops, no more. So that must be lowered if it is above that. If the patient is for conservative management or in the days after the ward, you can actually accept up to 220. There's this thing called permissive hypertension after an ischemic stroke, and perhaps the brain is trying to help reperfuse the ischemic components of the brain. It's not really known, but anyways, having a highish blood pressure is absolutely not a problem after an ischemic stroke. So don't treat if it's under 220 and you're not thrombolyzing. At the code stroke, we have this thing called the NIH-SS stroke score, the National Institute of Health stroke score. And this is really essential, because this is a way to grade the severity of the stroke. So there's a whole bunch of things here. It tends to favor certain strokes over others. So it's a little bit biased, but it's pretty good. It's pretty good. And we generally want the score to be at a 4 or greater, indicating a stroke that is at least sort of mild to moderate severity or greater, before we'll consider thrombolysis. If it's a 1 or a 2, we generally won't thrombolyze. A 3, kind of debatable, depends on how the neurologist feels. This is a very easy thing to calculate. You just go through and do it quickly. However, it's really essential to do it efficiently. And I would encourage you, if you're about to go on a night on call, or especially as doing a neurology register or service term, to just go through it and make sure that you have practiced it. And there are some videos online that you can look at to make sure that you're doing it correctly. Because if you don't do it correctly, it can actually drastically alter management. So after you do that, you race the patient to the CT scanner. So that history and that examination, it's ideal to try and get that all done within a few minutes. And that sounds very, very rushed, but really you're only focusing on a few things, and it's aimed at how bad is the stroke, how good was this person before, and what is the risk if I thrombolyze them. You're just doing a cost-benefit analysis in that first few minutes. That's really all it is. Stroke brain imaging. There's this concept called the 4 Ps. So it's good to know the 4 Ps. There's parenchyma, so that's brain tissue, pipes, which is of course the arteries, and perfusion and penumbra. And we'll talk about what those mean. So we image all these things, the parenchyma, the pipes, the perfusion, and the penumbra, and that allows us to have an optimal decision as to whether or not we should thrombolyze and or do a clot retrieval procedure. CT head assesses the parenchyma. That excludes hemorrhage, which is critical, and some of the mimics. For example, a brain tumor will generally show up on a CT head. Demyelination might show up. Some of them won't show up, though. It detects hypodensity as well. Hypodensity, if something's already dark, getting dark, then in a stroke setting, that usually indicates established infarction. Now, on this CT head, you've got dark areas, and that is just representing spinal fluid. There's no brain tissue there, it's spinal fluid. But when you've got it in a stroke setting, and it's going to be very subtle because it doesn't appear for at least 2 or 3 hours, you'll see some hypodensity, and that's not good to thrombolize in general. CT head is very useful for seeing the big clots. You can almost always see the big clots. So we have the right or left middle cerebral artery. The first branch is actually known as the M1 branch. And if you see a hyperdensity, so a little too white in that region, then we call that a dense MCA sign. And there's one there. So do you see that little hyperdense region, that little white area? It's about 1 inch long. You can see that that's basically a 1 inch long clot, occluding the left MCA M1 branch. And so now you can correlate that with the symptoms. Hopefully this person is probably presenting with right-sided weakness. There's also a dot sign in the M2 branch. It appears as a dot in or near the Sylvian fissure, which is that little black area just adjacent to the circle. And the other one, which is always good to look for, is the basilar artery, hyperdense basilar artery sign. That is a problem. So this is the dot sign. That indicates an M2 clot. I mean, if you're looking for it, it's quite clear, isn't it? And that is a hyperdense basilar artery sign. That would be the basilar artery's location. That is very bad, and that person we can thrombolize them. However, they will probably need a clot retrieval procedure to get that out. So your CT head gives you quite a bit of info. The best time to call the neurologist or the stroke physician, whoever it is you're talking to, is immediately after the CT head. People will vary, but in general, that's the best time. You get the CT head, you call the person up and say, okay, what do you want to do? Do you want to do the more advanced imaging, or do we stop it here? Because by that time, you have enough information to decide whether you're probably going to do something about this patient or not. And you do that with the patient on the table on the scanner. The CT head can be useful. We don't routinely do this, but depends on who's on call. They might ask you about this aspect score. Aspects is a score that assesses the extent of the hypodensity, how much established infarction or impending infarction already exists in the brain. And so that's important because we don't want to thrombolize in general hypodensity if it's subacute, because that means that, fresh strokes bleed like crazy. So you don't want to thrombolize that. And this was developed in Canada, the Alberta Stroke Program, early CT score aspects. And it's basically a measure of early ischemic change. It starts at 10, and then you subtract a point for all these predefined areas on the CT in the brain. Basically, a low score is bad, a high score is okay. So this would be an example. These are normal CT heads, and the white letters there show all the different areas. You don't have to really know the specifics, but you can see that basically that would be probably okay to thrombolize as the tissue is more or less normal. There's no major hypodensity. Compare it with that one. That one shows that basically there has been a huge left MCA stroke within the last few hours, within the last 24 hours anyways, and that is very bad to thrombolize. That infarcted tissue will bleed on you, and you'll make a bad situation worse. CT angiography assesses the pipes. This is really good for more accurately identifying the occlusion site. It's not always obvious on the CT head, even if you can see the clot. Thrombolysis works really well for smaller clots. So the M1 branch of the MCAs divides into 2 M2s, and they divide to M3s and so on. If you have clots in those smaller branches, thrombolysis is actually very effective at opening them up. But the big clots, so if you have internal carotid, M1, or basilar clots, the chances of thrombolysis opening that up are quite limited, and we're going to need a clot retrieval procedure for that, probably. So on this, you can see that the contrast in that left M1 artery, it just stops. You see that? It just stops. That white line should continue all across the circle, and it just stops. And so there's an occlusion, and it's going to be oligemia, low or reduced flow beyond that. And that is very important information to know, obviously. CTA also gives the clot retrieval specialist a number of other variables that are important. So they have to get it's a procedure, of course, and they have to get up to the clot intraarterially, and so they need to know what the aortic arch looks like. They need to know, we need to know how the collateral vessels are looking, because when you have a stroke, other vessels can sort of feed that penumbra for a period of time. How are they doing? How much time do we have? And the characteristics of the clot. Some clots are actually more difficult than others to retrieve based on the constituency of the clot and the age of the clot. CT perfusion assesses perfusion and penumbra. These are I gotta admit, these are my favorites. I find them very simple. They have aesthetically pleasing color maps as well. So I think it's really good if you can read these, although this is, this is generally done by the neurologist or on-call stroke physician. So these are useful for, really useful for identifying who might benefit from clot retrieval. And they're very simple to read, and you should be able to read them after this slide. So first thing we look at is the mean transit time, the rate at which blood is passing through a certain area of brain tissue. So MTT, mean transit time. And that is core plus penumbra. Remember, the whole stroke is core plus penumbra. It's two areas, core and penumbra. And then we look at something called the CBV, the cerebral blood volume. And that is the actual volume of blood sitting there. That tells you how much is core. So, of course, if you have something, the MTT, that tells you what's core plus penumbra, and then you have something that tells you core, CBV, you subtract the two, whatever's left must be penumbra. Yeah, that's it. So, for example, this is the, don't worry about the two maps on the right. Sometimes we'll look at those, but generally we don't need to. So the MTT is the bottom left one here, and you see this blue region, which is corresponding to the left MCA territory. Probably there's an M1 clot there, or maybe an ICA clot. And clearly there's a reduced mean transit time. So that is the core plus penumbra, but it doesn't tell you what's core and what's penumbra. So then we look at the CBV, the cerebral blood volume, and you want to see if there's any change in color there. That would be core. Now there's a tiny black region there. You can see that sliver of black, and that would be the core. Most of the brain tissue on CBV looks normal. And how do you know? You compare it to the other side. So that means most of this particular stroke, despite the huge area of blue, most of that, like 95% or more, is penumbra. This is an excellent candidate for reperfusion. So we call this an MTT-CBV mismatch. It's mostly penumbra. And most of that is stunned brain. It is potentially salvageable. This is a patient we'd really try hard to do something about in order to save all that brain tissue. Because it may last for a few hours, but eventually the chances are that it will infarct. Now, if you have an MTT-CBV match, so let's say the CBV looked all dark compared to the blue region and it matched, well, that would be indicative of mostly core, and in that case, it's too late. We can't, there's really not much point in reperfusing because we've missed the boat. Okay, that's it. That's CT perfusion, very useful imaging modality. We've only had it at Waikato for the last 5 years or so. Now, the computer can also create summary maps. It sort of imposes them on top of each other, and you can see the little red area there corresponds to core, and the green corresponds to penumbra. So if you really find it, the eyeball method difficult, although your eye is actually very good at reading those, you can use a summary map. I have to caution you, the summary maps are not always reliable, so I prefer the former method. Stroke reperfusion therapies. Okay, so there are two of these. Thrombolysis, obviously. We use alteplase. There are other agents one can use. Within New Zealand, some people use tenecteplase, other hospitals, particularly down south, but Auckland and Waikato use alteplase. It's very important to know that because the doses do change, and you must make sure you know if you're dealing with alteplase or tenecteplase. And these are based on tissue plasminogen activators that catalyze plasminogen to plasmin, and basically they dissolve the clot. When I describe this therapy to a patient, I say it's a clot buster. I think that's a one-word way to really get the meaning across. Clot retrieval, which we can do up to 6 hours, up to 24 hours, as we do have CT perfusion available, uses a variety of devices to extract the clot, and all the clot interventionalists I've spoken to have tried several different devices, and they often have their favorites. I believe we still are using the solitaire device. The Auckland specialists are still using the solitaire device. And that's essentially, you thread a little piece of metal, a mesh all wrapped up through the clot, and then you expand the mesh and you push the clot apart and pull it out. quite simple. So if the decision is made for thrombolysis, there's a few things one needs to do. First, as I said before, make sure the blood pressure is 185 tops, no higher than that. And the INR can't be above 1.7. I even get quite nervous at 1.5, 1.6, 1.7. But APTT, less than or equal to 40. Ideally 2 lines, the ED should do that for you, and insert a urinary catheter, ED should do that as well. The stroke nurse will join you on every single code stroke, and the stroke nurse, if you give the go-ahead, will mix up the alteplase. The total dose is 0.9 milligram per kilogram, up to a maximum of 90, and you give 10% as a load. That load is really important because when you give the loading dose over 30 seconds, that counts as the time the patient received the alteplase. And we're really trying to get our door-to-needle times, the time the patient arrived at ED to the time they got the loading dose. That's key time. So that's something we try to emphasize always. You give that over 30 to 60 seconds, followed by a saline flush and on a scanner if possible. We're still working on that as a protocol. And then the remaining 90% is run through over 1 hour through a syringe driver, and the patient is typically moved to the stroke unit immediately before this or even during. So during the infusion, that 1 hour, it's necessary to stay with the patient, keep an eye on their vitals, neurological signs, whether they're improving or worsening, hopefully improving. And I check the tongue. I don't do this anymore, but when I was reg, I would always check the tongue. Tongue swelling can indicate impending anaphylaxis, and that is, I've had 2 of those. They're easy to manage if you catch them early, but very, very problematic if you don't. And afterwards, just fast the patient for their speech path review with intravenous fluids and order repeat 24-hour CT head for the next day. If we decide for clot retrieval, it's a very streamlined process, getting more streamlined by the day. So we first have to ask the radiologist to load the imaging onto the system so the Auckland specialist can see it. Next, call and provide the patient details to the Auckland neurologist through the Auckland switchboard, and then arrange a helicopter transport if they accept the patient. That's it. And then patient is essentially whisked away. It's not always as easy as it sounds. There are often delays and other problems, but that's the essence of it. And up in Auckland, if they use their solitaire device, they hopefully will extract the clot and come out with something that looks kind of like that. All right, so regardless of which of these one uses, or whether you use both or whether you use neither, once any acute treatments have been administered, so those are to treat the current stroke, then you're actually only halfway to the diagnosis, because remember, the stroke is not the diagnosis, it's part of it. And so now it's vital to identify the TIA or stroke etiology, and I can't emphasize this enough. This is the part where I think we actually fall down more than anywhere else, because it's so important to find out the source of the stroke or TIA so that you can prevent more. The etiology is diagnosed using clinical clues and investigations. So clinical signs and symptoms are great clues to etiology. If you have these things called cortical signs, and you all know what cortical signs are, even if it's not coming to you right immediately, cortical signs are critical to know, because they indicate that the neocortex, which is, it's almost synonymous with the term cerebral cortex, that little gray area around the edge of the brain, it indicates that's almost certainly involved. The thalamus can also give you cortical signs, because this thalamus is a very central structure that everything basically runs through, but in general it means neocortex. And the 3 most common cortical signs are aphasia, particularly with a left cerebral hemisphere stroke, neglect, particularly with a right cerebral hemisphere stroke, and hemianopia, which is very common with occipital lobe stroke. So if you have these cortical signs, automatically you're probably looking at large artery atherosclerosis, like a carotid plaque or something, as the source, or cardioembolism, usually atrial fibrillation. However, if the patient presented with a lacunar syndrome, that indicates it's probably a subcortical structure involved. And there are many of those, the brain stem, the thalamus again, the basal ganglia, and so on. So there are these 5 classic lacunar syndromes, and they are pure motor hemiparesis, pure sensory hemiparesis, sensory motor, so a combination of the 2, ataxic hemiparesis, where a person presents with both ataxia and hemiparesis, and this one called clumsy hand dysarthria syndrome, where they have exactly that. And so if you get any of those classic presentations, then you think small vessel disease. And I guess just throwing some numbers at you, you probably, roughly in New Zealand, you'd have about 25% of New Zealanders over the age of 50 would have a small vessel disease as the source. Probably 10 to 20% would be atherosclerosis, about 40% or so AF, and then the rest would be cryptogenic, unknown. Those are the older population, over 50. Okay, so speaking of age, most people who get strokes are over 50, say, I think it's changing, but about 90% of strokes are over the age of 50. And this is Marlon Brando when he was definitely over 50. So you want to do, again, your two essential investigations, blood vessel imaging. Again, you should understand why that's so critical now, because you're seeing if there's large artery atherosclerosis. Do they need an endarterectomy of the carotid? It doesn't have to be the carotid. It might be atherosclerosis in another artery, particularly a vertebral or basilar. Cardiac monitoring, because if you find paroxysmal AF or AF, then clearly an endarterectomy is not going to help you. You need to anticoagulate. An extended workup is indicated for people who are young strokes. And young is usually, by most centers, defined as age 15 to 50. But you can do this for the people over 50 who you feel strongly about, perhaps someone who's extremely highly functioning or some other reason. So blood vessel imaging and cardiac monitoring, again, always do those two. But you can do more advanced imaging if necessary of the vessels. So in addition to the CT angiogram, you might want to do an MR angiogram. That's really good for dissections. MR angiogram looks at soft tissue. And digital subtraction angiography, which we rarely do. And we very, very rarely do that. Cardiac imaging is often important. So you can do a transthoracic echo, the TTE. If you have a young stroke and you haven't quite got the info you need and you haven't found the source, you probably should order a transesophageal echo, which is a TOE. And up until a couple of weeks ago, I had not seen cardiac MRI at Waikato Hospital, but now I have. So cardiac MRI in extremely rare instances. Thrombophilic blood testing might be indicated, and there are other things you can do. It depends on the situation. Generally, these patients will be under neurology because anyone under the age of 45 or under comes under neurology with a stroke. So why do we do these things? So the clinical clues and investigations allow you to classify this crucial thing called the toast etiology. And this is something that was sort of formed a couple of decades ago. And basically, the etiology of stroke can be divided into 5 main categories. These 3 categories here describe the majority of strokes in 50 and over people in New Zealand. So large artery atherosclerosis, cardioembolism, and small vessel disease. The 3 different pathologies, they really do need completely different treatments. Cardioembolism is usually AF or paroxysmal AF, but it can be things like artificial valves, a recent MI with akinesis there. So there's turbulence, akinesis, clot conform. And it's so critical to figure these out. And there are 2 other categories, but the 4th one is particularly important in the younger strokes. Arterial dissections, we do see quite a few of those. Vasospasms, recreational drug use is unfortunately becoming more common as a stroke source, and thrombophilic disorders. There are dozens, actually. So I just didn't have the slide room to write them all down. And then there's an undetermined etiology, cryptogenic strokes. Probably if you do all the work and try hard enough, still about 20% of the strokes, you're not going to find the source. So the final diagnosis, what should be on the discharge summary, is whatever the kind of stroke was, secondary to the etiology, whatever that was. Remember, stroke is a sequelae of the true disease. In stroke, the brain is not the problem. It's something else that threw a clot at the brain. Okay? So in that sense, it's almost not some neurologists say it's not a neurological disorder. So I'm not going to get into that. But we treat the etiology, not the stroke itself. So if you have this is your MRI, and that's like a right MCA stroke. And then you have an ECG, which it's not extremely apparent, but it shows atrial fibrillation. Your diagnosis is right MCA stroke secondary to AF. So critical because you're not treating the right MCA stroke. You're treating the AF and thereby indirectly preventing further strokes. Make sense? That's hyper critical. And I don't find that it's often taught. So here's a quick approach you could use in stroke. So first, Take your quick focused history. It's the backbone of every single disorder in neurology. Exclude the stroke mimics. You might need collateral. Then clarify these two vital things, the premorbid function and the time lasting well, not the time lasting unwell. Consider if it's a code stroke. If the answer is yes, then look for contraindications to thrombolysis. Do a rapid examination. You want to check hemodynamics, especially the blood pressure, and make sure it's within 185 systolic if you're thrombolizing. If you're not thrombolizing, up to 220 is okay. And of course, you can also check for atrial fibrillation right now. It's very easy. Just feel the pulse or look at the monitor. Assess the stroke severity by calculating the NIHSS score. If you have a TIA, it's all about stratifying imminent risk. So the person's had a symptom, it recovered fully within 60 minutes. So if you stratify them as a low risk, outpatient is fine. High risk, they probably need to be admitted. Stroke, you need to do bloods, brain imaging, consider thrombolysis, consider clot retrieval, depending on if they're in the time windows. And finally, once the dust is settled and the patient's on the ward, then you identify and treat the etiology. So one must understand the importance of identifying this. I hope that you all understand the importance of that now. You can do a standard workup, which at a minimum must include blood vessel imaging, cardiac monitoring, and of course the basic bloods for cholesterol and so on for all patients, and an extended workup for young patients, ages 15 to 50. We really work hard to find the stroke source for younger patients in particular. I mean, all patients, of course, but younger patients, they shouldn't be having strokes at all. Ensure that you treat the toast etiology and modify any related risk factors. And lastly, I should say, ensure the diagnosis is very clear to both the patient and the GP. Otherwise, they don't know what they need to do or what they're treating really to prevent further strokes. So, in conclusion, in TIA and stroke, always consider the possibility of a mimic. If you think you have a TIA, so sudden maximal onset with rapid full recovery within 60 minutes, use that ABCD2 score to determine whether they should be worked up as an outpatient or an inpatient. If there's a code stroke, do a quick focused history and exam and order the brain imaging. See if the patient is eligible for reperfusion and call the neurologist after the CT head. Afterwards, identify and treat the toast etiology for stroke prevention. Don't forget that fourth point, very important. Otherwise, you might find you've seen the same patient 2 years later. Thank you very much.